And I've tried to make this fairly informal. I don't want to just talk at everyone, but obviously if you're eating and you want to save your questions, that's fine, but please feel free to interrupt. And if, I may not be able to see hands just because of the view, so just shout out and start yelling if you want me at all. So I appreciate it. So I'm going to chat about EGFR lung cancer specifically, and I'm going to talk both about the common EGFR mutated lung cancers and a bit more detail on the data and the toxicities of those treatments. And then in a much more cursory way, I'll talk about EGFR exon 20 and the other uncommon EGFR mutations, all in the advanced setting though. So here are my disclosures. I should note that I will be talking about amivantamab, which is a Johnson and Johnson or Janssen product, as well as osimertinib, which is an AstraZeneca product, and very briefly about a TROP2 ADC that's owned by Merck called sac-TMT. But anyways, so as as we know, we learn about different when we're going through our training, we learn about different cancers as, lung cancer and non-small cell lung cancer and kidney cancers and so on. But really, EGFR lung cancer is sort of a subtype of a subtype because a vast majority of EGFR lung cancers are adenocarcinomas from within non-small cell. And then if you look at this big pie chart of pink here, and then over into the side group, the group over here of the small, I don't know if you guys can see my cursor, but so the smaller pie with a whole bunch of pink and one kind of tealy green. So that is the three biggest colors, the three first pieces there going clockwise, starting with the teal. So that's EGFR common mutations, uncommon, and exon 20. Now, if you see 20 different papers, you'll get 20 different percentages, much like sometimes we see that ALK is 1% or 5% or 6% or 2%. The same is true. Different populations, different tests will come out with different numbers. But in general, the uncommon mutations are not really quite as uncommon as their name seems as our testing becomes better. But certainly the common mutations, exon 19 deletions and L858R, the exon 21 point mutation, make up a majority. And these mutations are actually very different depending on where you work. So in your area where, there are populations of, areas that have large East Asian populations, you have higher rates than we would have. Whereas likewise in London, it's quite a bit lower. And so in Ontario, it averages out to be about 23. But when you start to include all kinds of more Caucasian, rural areas with higher rates of smoking, it drops. And for where I work specifically, on our old panel, which may have missed a few complicated insertion deletions, it was actually only 11% of patients who had the panel testing for lung cancer. This is our old panel before it even had fusions. Only 11% of patients had EGFR mutations. And a fair number of them, about one third, had some form of an uncommon mutation, although some of those are actually compound mutations. And the T790Ms were also tested on that panel back then, so it kind of skews it a bit. So the reason we care a lot about EGFR is not just obviously to provide good care for our patients, but it really is a fairly different type of cancer. It's more likely to present with, advanced disease or small primaries that metastasize early, including to the brain. So this cancer compared to sort of general wild type EGFR, like normal non-small cell lung cancer, does go to the brain and the leptomeninges more often. And so this is really there's no fancy algorithm that I show to start. It's really just every time we see a new one of these patients, we now have three different treatment options that we can consider. All three of these are Health Canada approved. The bottom two there are available through access programs and are awaiting different types of, awaiting a funding decision. Aussie monotherapy is long funded. But the problem is we don't treat people like they're on trials. So these are our three different options, but it's obviously a lot more detail. Well, if one of these had a better overall survival, we don't necessarily just use it blindly for everyone because there are complications, really. There are lifestyle factors, there's toxicity factors. And these trials, as we all know, they not only restrict who can get in, but they also restrict how you're able to treat people. Can you treat beyond progression? How do you use SBRT? Can you treat oligoprogressive disease and keep them on study? Can you treat oligoresidual disease if you want to consolidate some of your treatment after a couple of cycles on osimertinib or osimertinib and chemo or AMI laser for that matter? So all of this kind of goes into how we help patients make the right decision for them. And I'm sure our own biases of what we think works well and quality of life also play into how we have that conversation. And so I won't spend much time talking about the evidence for each of these, but really quickly, especially if there are learners or people who are new to the lung world, the reason we use osimertinib single agent is based on the FLORA study. And so this was a study where they compared osimertinib to the old EGFR drugs, erlotinib and gefitinib, but not afatinib, which I used over the others, but it was also more toxic. But regardless, um, and this all came after osimertinib was shown to be effective for patients with T790M resistance mutations to these drugs. So the whole idea was by giving the better drug up front, can you suppress or prevent that T790M mutation from ever forming and will it work better? And this is the overall survival. I'm not showing the progression-free survival, which was even better, but the short answer is yes, people do better with this drug for a few reasons. One, only about half of people who get the old drugs develop a T790M mutation, and osimertinib gets into the brain better. It actually has less off-target EGFR toxicity in terms of like the skin toxicity, especially if you compare it to afatinib. So I think overall, this was a study that really changed things. And this was a very unique study for us because this was one of the few cases where the better drug was not only more effective, worked better in the brain, but also was less toxic. So it was a really nice win. It's one of those few cases where where you know you want to use the new drug because it's better in multiple ways. And on study, patients had an overall survival of about 3.5 years with osimertinib. Although, again, I do believe, even though these are trial selected patients, I do think with doing simply radiating oligogressive disease or even potentially as a non-responsive disease and so on, I believe we can actually do better than this, even without having access to any new kind of subsequent lines of therapy than what was available at that time. And so overall, this was a unique drug where it was effective. It got into the CNS well. It had a fairly good safety profile. There are risks with it, including pneumonitis. So you have to be careful in how you combine it with any type of thoracic radiation, or if people have had recent immunotherapy, like if they progressed after, say, chemorads because they had stage 3 disease. If you gave durvalumab, you have to be careful if there's immunotherapy in their system because of the pneumonitis risks. But also, that this is a drug that has fairly good quality of life. Again, there's a rare cardiac risk with this as well. But overall, a very well tolerated oral therapy that we can often send people away for months at a time. Sometimes 2, 3 months before we see them again. People can travel. They're not getting IV treatments regularly and so on. Sorry, I just was checking the chat. Now I have to get rid of it. There we go. So then came these two new studies, and I will zoom in on them a little bit in just a minute. I'm moving a little bit faster than I thought I would, so please interrupt at any point if you want. But the two new trials are first Mariposa. So in this study, patients got amivantamab and lazertinib, and I'll come back to the schema in a second. And the other one is Flora 2. So this is much like Flora, which showed osimertinib was better than the old TKIs. Flora 2 is adding platinum pemetrexed to osimertinib. And so I'll zoom in on that one first. So in this study, patients were randomized to either osimertinib single agent or to osimertinib with 4 cycles of platinum, as well as pemetrexed, and the pemetrexed maintenance continued with the osimertinib. So I think this is the factor in this study that really makes us think a lot more about it is, you know, what do we think of giving maintenance pemetrexed to these patients, who have a median treatment duration of 18 to 24 months, Q3 week pemetrexed for them. And sorry, that's based on old osimertinib data, as I'll show in a minute, even longer with current treatment or with this in this study. So Do we want to give people maintenance pemetrexed? Do we have to give it to them this whole time? So there's certainly questions that even this design brings up, but this was the study. And so I'm going to cover toxicity first, then I'm going to come back to the efficacy with both studies at the same time. And so what you see here is I didn't show the osimertinib toxicity before on purpose, knowing I would show it now. But what you see is there is diarrhea with this, but remember the way this is collected on study, it doesn't mean all patients or even 40% of patients on osimertinib will have diarrhea throughout their treatment. What it means is that when they were doing their CTCAEs, that 40% of patients at some point reported true watery diarrhea while on osimertinib, and only about 1% had grade 3 diarrhea. So, of course, we talk a lot about grade 2 diarrhea can be a big deal for a patient, but this isn't necessarily all throughout treatment. There are options of dose reductions, the use of loperamide, dietary changes. But diarrhea is something that many people do deal with, or, I have many patients on this drug who they have a good quality of life, but if they're taking a 4-hour car ride, they might take Imodium before, or they time their travel around their bowel movements if it's predictable and so on. But so we also see some EGFR toxicity with osimertinib, including rash, stomatitis, paronychia. Paronychia, certainly most of my patients, they curse that they can't open ketchup bottles with their fingernails and things like that the way they would like to. But for the most part, these are things that certainly acne form rash, sun sensitivity, these are things that can affect quality of life, but are generally quite tolerable. When you look at chemotherapy, of course, we see the expected, sometimes high grade chemotherapy toxicities, which don't always make people feel that bad. They certainly can, or they can be serious and cause hospitalizations, delays. But we also see increases in some of the osimertinib toxicities, both probably because people are on them, but that there is some overlap of toxicities. So when you look at some things like fatigue, vomiting, nausea, that there's an element probably coming from the pemetrexed even after the platinum doublet treatment, as well as an element coming from the osimertinib there. So we do see some increased toxicities that are likely to affect people's quality of life, even when they're out past those first 4 doses of platinum doublet chemotherapy. And an important thing I do want to mention here, because I think this matters for how we use this in our clinics, is that in the end, without progression, so 43% of patients stopped osimertinib at some, or sorry, pemetrexed maintenance at some point. And I think this is important because even on the study, not everyone stayed on the pemetrexed. And sometimes that was patient preference, physician preference. It wasn't always because these people were developing, pemetrexed rash or kidney dysfunction, which certainly can happen when you're on it for a long time. And I don't actually have the median cycles, but that has been presented. But, again, a lot of people didn't get nearly as much pemetrexed as they did in terms of time on treatment with osimertinib. However, it's pretty rare that people die on therapy from osimertinib monotherapy. 3% of patients from osimertinib, but as you can see further down under causality related death, only about 1 death was related, they believe, to osimertinib monotherapy. That increases slightly on when you get into the combination, but certainly there are higher numbers of SAEs, so people being admitted to hospital, higher numbers of drugs being discontinued. Even osimertinib gets continued more often when they're giving it with chemotherapy at the same time. Sorry, and I'm just noticing the question here. So I think is the question how like do we see more people stopping pemetrexed in the study with osimertinib compared to what we would see on chemoimmuno?
Correct. Correct.
Yeah, I don't actually have a number for chemoimmuno, what percentage stop, but certainly I think there are people with PD-L1, weak positive disease, who are getting, or even PD-L1 high if you chose to give them chemoimmuno, and that are getting long-term IO benefit that clinicians might have a varying level of comfort stopping the pemetrexed. So I think this is higher than what I would expect we would see with chemoimmuno. But certainly in some people who have prolonged benefit control, like control on pemetrexed pembrolizumab maintenance, I think it would get up there. But because many people only get 6 months or so, I think a lot of those are on pemetrexed the whole time. But I don't actually have a real number to give. But definitely this is higher than what the average chemoimmuno patient in terms of stopping without progression would be. But great question. So, so now sorry, there we go. So in terms of there we go. So in terms of the other study, so Mariposa, so this was a study, it actually had 3 arms, amivantamab lazertinib against osimertinib, and that was the primary endpoint. And the data I show today, there was also a lazertinib arm to measure the component of each, like of the lazertinib factor. And basically, I can tell you that lazertinib performed the same as in terms of PFS as osimertinib, but it did have more skin or off-target EGFR toxicity compared to osimertinib, with the exception of less diarrhea and no concerns around QTc prolongation or cardiac, but more rash, more stomatitis, and so on, even without amivantamab added. So in terms of Mariposa, so this is text is small, so I don't know what if some of you are in a large room as opposed to your computers, I don't know how well you can see it, but so I put red boxes around it. When you give someone amivantamab and lazertinib instead of osimertinib, you certainly see higher rates of these wild type or natural EGFR toxicities. So paronychia, rash, again, not so much diarrhea, but the acneiform rash, stomatitis, and so a lot more. And some of that is driven by lazertinib, but certainly some of it is driven by the EGFR monoclonal antibody portion of the bispecific antibody that amivantamab is. And I didn't say that. So amivantamab is an EGFR MET bispecific antibody. And so the whole idea is because osimertinib resistance, a portion of it is MET amplification, and another portion is EGFR upregulation or EGFR off-target mutations. And the whole idea is that you're with that bispecific is you're actually kind of targeting 2 different major resistance mechanisms. And of course, the idea of targeting something with both the TKI and a monoclonal antibody in general might drive better benefits. So that's the rationale for it. But it comes with toxicity again, because there's 2 different EGFR blockades there, both monoclonal antibody and the TKI. Now, the MET component does add some hypoalbuminemia and peripheral edema as well. And so this is something that I think a lot of us are using dose reductions and skipping a cycle of amivantamab for and so on when we need to. But this can be a real factor. Now, some of my patients, like when I think back to single agent with this drug in the exon 20 space, um, the hypoalbuminemia in a lot of these young fit patients was more worrisome just in terms of the number. I didn't have a lot of them actually have nearly as much leg edema, but some of the older ones now with chemotherapy, I have seen that a bit more. But it can be fairly nerve-wracking when you're watching an albumin go all the way from 44, slowly down to 20, and you're thinking, how low could this possibly go? But anyway, so there are issues, but dose reductions and skipping cycles of it with this drug can help with that. Now, there's also infusion reactions with this, particularly cycle 1, day 1, and cycle 1, day 2. So for those of you, I don't show a schema of how this is given, but it's given IV, split up over the first, so it's given weekly for the first 3 weeks, and then every 3 weeks thereafter, when you give it with chemo at the same time. When it's given single agent, it's every week for the first 4 weeks and every 2 weeks thereafter. So depending on the regimen, it changes a bit. But the first 2 doses over the first 2 days have a very high rate of infusion-related reactions, like a bit higher than rituximab even, which I don't have much experience with, but so very high rate. So these people need to be pre-medicated, which is part of the standard way of giving this. And I'll come back to this of how some of the ways that it's dealt with, even though I'm not going to go over the Skipper and Cocoon data in detail, but I'm happy to chat about it. So which covers how to prevent some of the skin toxicity and the infusion reactions. So what happens though with this Mariposa when you give amivantamab and lazertinib together? Well, a lot of patients need dose reductions or dose breaks at times. So as you can see there, 83% of patients have some form of a dose delay or a dose interruption or skipping a cycle. of one or both drugs. And actually, one-third of people will stop one of these drugs outright. Generally, that was the amivantamab more than lazertinib, because of course the idea is, well, we know the EGFR TKI has efficacy on its own. As you can see with osimertinib, it's quite rare to have reductions, only 5%, and to discontinue osimertinib in the absence of obvious progression is also not totally uncommon, but fairly rare. So now, what I mentioned before about giving amivantamab, it requires, kind of the full prophylaxis beforehand. And what I've added in red, because the what came out of Skipper isn't there, and that is that it's now recommended to give Dex 8 BID for 2 days before those first 2 days of amivantamab. Now, don't follow what it says there necessarily so much. So when you're giving it as AMI laser, it's a bit different than when you give it second line with chemo, because with chemo, you're probably giving Dex 10 milligrams as well. So that's why that's there. If you're giving AMI by itself without chemo, you need to give this. I personally give montelukast as well. So in Skipper, there was also an arm checking montelukast. It did numerically improve things, but not to the level that it was required to go to the dose expansion. Only the Dex 8 BID met that. But I actually give montelukast days 1 and 2 only, and then I stop. I don't give it beyond there. But I have actually found, anything to reduce infusion reactions and have them in the chair for like 8 to 12 hours, like so hours longer than they need to be, what is really important. So I give the montelukast there as well. So this drug, as I mentioned, also causes increased skin toxicity, and this is the same. This is a problem when we give it in second line, which I'll come back to as well. But so much like monoclonal EGFR monoclonal antibodies, if you're giving them in GI indications like panitumumab or cetuximab in colon cancer, or if some of the old information from afatinib, or if you are participating in trials with more toxic EGFR drugs like poziotinib and things like that in the past. So one, you can consider prophylactic tetracycline. So I often use minocycline. I like it more than doxycycline. I do give it from the start, much the way the STEEP study said it with panitumumab. You can prevent some of the skin toxicity with EGFR monoclonal antibodies without compromising efficacy. And I also, I give them the hydrocortisone clindamycin skin cream from the start. And so I give all of that to them right up front. I do get them involved. The program to connect people with this drug also, offers skin care programs and additional education information. And I connect them with all that. And I do warn them, it's our summer times. It's wonderful to be outside, but that they need to take additional precautions with the sun. So in terms of the results of these, so I'm going to show them together because I actually kind of want to make the point that I think the results are overall quite similar, even though there are numeric differences between the studies. And there are, patient characteristic differences. I didn't also mention in Mariposa, patients were mandated to have brain MRs serially on study to a high degree. So there are some cool things about the study that I won't get into. But really, in terms of PFS, both of these studies show an improvement in progression-free survival, the hazard ratios being 0.7 and 0.62. But regardless, both of these show similar and early distinctions between the PFS of these two different strategies compared to osimertinib monotherapy. So we're not showing the lazertinib single agent arm in this. When we move on to overall survival, which is, really what matters in this disease in many regards, again, very similar results. So now I should say Mariposa's survival has been updated at ELCC this year. It is statistically significant. The Flora 2 has not yet reported its overall survival, like its final overall survival. So even though this overall survival data that you see here has a p-value of less than 0.05, this is an interim analysis. And so the p-value threshold it needed to hit to be significant was, astronomically large. So this is not a statistically significant result. But as you can see, curve-wise, they're very similar. Hazard ratios, again, in that point 0.7, they're both 0.75 exactly, but in that 0.75 range. What I will highlight with that red box, though, is again, I don't think you can see my cursor, but you'll notice the blue line, AMI laser, is on the bottom inside this blue box at first, and then it crosses over and it's sustained. Same thing with the uh, FLORA2 curve. There is a period where the chemo-containing arm has an inferior survival, and then the curves cross over. They cross over a little bit later, but in general, both of these curves cross over around 12 to 15 months. So I think there is a group of patients who are being harmed with this more toxic regimen, whether it's because they have toxicity from treatment and that leads to their decline, whether they stop all therapies. But certainly there does appear to be some harm in a small group of people with this more aggressive treatment approach. But in general, these look like treatment options that can prolong survival. So to go back to that same algorithm or the same option list of options I showed at the very start, you have these three different options, and I don't really get into many of the different factors, but both of these studies, FLORA2 and Mariposa, have shown that there are high-risk subgroups who benefit more, and that includes patients with brain mets for both studies, those with liver mets, TP53 co-mutations, in general, some younger fit people who you would probably be thinking of this strategy more for. But so there are people that you might more align with one of these, and of course, you can do the same in your head with toxicity. Someone who has very acne-prone skin, fair skin, issues that you're really worried about skin toxicity, that might affect you one way. Whereas someone who really, someone who doesn't want IV treatment, someone who has a contraindication to, maybe immunosuppression, again, you're going to view differently than different people. Someone who's old, they don't have brain or liver metastases and so on. And so the other thing I really think is important is we don't know, one, we don't technically know if FLORA2 or Mariposa will be funded in Ontario. Even if they are, we don't know the details. Like if you give FLORA2, will you be able to give Mariposa 2, which I haven't shown you yet, but which is AMI plus chemo second line. And so if you can't, then is that going to affect the decision you make in first line? I don't, sorry, Young, I don't know when that comment first came, but um, so in terms of co-mutations, sorry, so I don't know if you guys can all see the question. So are there co-mutations that would influence what we might pick? And so in general, I would say probably I mean, TP53 is the most common co-mutation that we would see with osimertinib. There are some co-mutations that predict a lack of response to osimertinib. I'm blanking on the name of the one that was presented at ASCO 2 years ago. We don't get it here. But anyway, so certainly if there was a co-mutation that was really worrisome. And the other thing would be if you get variant allelic frequencies, in the very rare case that one of your patients has a EGFR and a KRAS mutation, even if it's kind of subclonal, those are people I would absolutely consider giving chemo to because I don't think you could rely on the osimertinib by itself or maybe AMI laser in that case too, So if someone had a co-mutation like KRAS, which they, although they should generally be mutually exclusive, we know people with KRAS mutations who get EGFR TKIs do not do as well with them. Again, both probably because of the pathway and because of a clonal bit of disease. So anyways, going back to the different options. So what we do know is how can we give osimertinib? And the way those forms work, as long as they don't progress or they don't, as long as we can kind of spin it in our note that they're still having clinical benefit, we can generally keep the osimertinib going. So we use a lot of radiation to complement osimertinib, particularly for oligoprogressive disease, but there is evidence, which I'm not showing, for the use of SBRT sort of into lesions that don't fully respond in this oligo-residual disease, or even just sort of this large bulky areas, just to reduce the tumor burden, to reduce the likelihood of forming disease that will be resistant to osimertinib in time. So basically to beat down the tumor burden. But then what about Flora2? Maybe if we're allowed to use this kind of willy-nilly, maybe we'll give Flora2, but maybe we'll stop the pemetrexed maintenance at the same time as the platinum. Or maybe we only keep it going for a few months and, if there's signs it's all going well, maybe we stop it. And if there's a bit of a hint of growth, maybe we restart it. So the way we use this, I think will depend on our funding quite a bit too. And of course, this doesn't follow how it's used in the trials, which is, I'm not saying we should treat people in a non-evidence-based manner, but of course, we're physicians, people are people. We have to kind of think outside of the box and outside of evidence in ways too. And in Mariposa, likewise, there are going to be people who want more aggressive treatment without cytotoxic chemotherapy. So this is going to be right for some people. As once amivantamab's available subcutaneous, that will be a benefit because then we'll be sidestepping the additional chair time that's needed and the intense initial period. It's too bad lazertinib is more toxic than osimertinib, because if it was amivantamab and osimertinib's profile, maybe it would be used even more, and maybe that would be good for patients. So I think there's a lot of different factors that will go in to how we're able to use this. Oh, sorry, I didn't switch. There we go. So, and I think another factor is what we can use later. So I won't spend a lot of time on second line because now after I first thought I was moving too quickly, now I think I'm moving too slowly. So basically, what we would use next varies. So if you use Aussie monotherapy, it's very clear you can move on to Mariposa 2, which is this AMI platinum pemetrexed. But if you use Flora 2, it's not so clear if those patients would benefit from Mariposa 2. And certainly you would have to have stopped the pemetrexed at a stage that you still felt it was pemetrexed sensitive disease. Otherwise, you're on to docetaxel, which is, it works, but it's not great. Even I use it at 60 milligrams per meter square generally. Sometimes I even try and add VEGF, like bevacizumab to it, kind of like the Rebel study. But basically it isn't the best. And so we're really looking at clinical trial options here. And then if you use Mariposa, then certainly you're not going to give AME second line. So you're looking at platinum pemetrexed. And I'm not saying it doesn't work, but it's obviously you feel like you've got left in your pocket when someone's on Mariposa compared to when they're on Aussie monotherapy, for example. So really quickly, just to mention second line data, because it's somewhat new as well. So Mariposa 2 was a study that showed a combination of AMI plus chemo against chemo. The AMI laser chemo arm, I'm not going to spend much time on. It added toxicity and things like that, but really not a lot of uh, reason to use it. But I'm not saying it's a complete no, but not something we have access to anyways. So here is a graph showing all three arms. So as you can see, that greeny color on top, AMI laser chemo, is not a lot different than AMI chemo. And I won't spend time on it, but the reason they kept the lazertinib in was in case they needed it for CNS protection, but it didn't seem to increase the CNS protection really. And there were certainly complications around how you have to give the chemo and the myelosuppression and blood clot risks and stuff with that combination as well. So if we focus on chemo versus AMI chemo, you can see a clear improvement, hazard ratio of 0.48. So a clear improvement when you add AMI to second line chemo. And here, looking at AMI chemo versus chemo, you can see clear benefits across subtypes. Um, for once, L858R actually do even better with something. Usually, if you remember from Aussie, there was a lower degree of benefit. So it's kind of interesting that they're seeing a higher degree of benefit here. And again, all kinds of, patients with brain mets or not, many different people are benefiting. I won't cover this because it's actually come out with a press release saying they didn't quite meet the survival endpoint. So the confidence intervals just slightly cross one. But this was a study where Harmony A, so this was using a VEGF PD-1 bispecific along with chemo against chemo alone. And it had, again, a hazard ratio of about 0.5. So very similar to the Mariposa 2 study. But again, how that this was all Asian patients for one, and two, now that they didn't actually meet their overall survival endpoint so far, according to a press release, we don't have the full data. I'm less confident that we're going to see this in the future, although I was never very confident. So just to kind of wrap up common EGFR mutations, so osimertinib monotherapy, I think will honestly still be a very frequently used treatment, especially if we don't have the flexibility of kind of giving less chemo than FLAURA2 suggested. Some of these patients want the quality of life, they want the oral only option. Not all, but many. Some people will certainly be well served with the more aggressive treatments. There is a survival benefit with it at the expense of some toxicity and convenience. And of course, we'll try to have our cake and eat it too and figure out how we can maybe give Mariposa 2, even if we give Flora 2, for example. What will we use after? Well, at some point, we'll use docetaxel. There is a study showing, so one, in addition to the tropion lung, which was a drug called datopotamab DXD, which I won't show that data, um, that was an all-comer population in one study, in the randomized study against docetaxel, or single arm in the AGA population. But at ASCO this year, there was a study of sacituzumab tirumotecan, or SAC-TMT, which is Merck's TROP2 ADC. And compared to docetaxel in an EGFR positive population, common EGFR positive population, hazard ratio of 0.3. And I'll move right on. Statistically significant survival benefit. Mind you, this is a smaller study of only about 130 patients, but survival benefit, PFS benefit, the FDA is considering datopotamab deruxtecan, but only in the EGFR positive population. Daiichi Sankyo and AZ pulled that application from Health Canada in light of sort of how it was being reviewed and the FDA's recommendation for EGFR only. So to summarize, patients with common EGFR mutations have more options now. It is not going to be clear cut what we should use or when we should use it. A lot of that's going to come down to what the patient wants, what the clinician wants, and what patient factors are there and so on. How we can use Mariposa 2 will influence what we use in first line, I suspect. But at the end of the day, we really don't have a lot of good options. The ADCs have not panned out to the degree one would have hoped. Herthena was a negative trial of a HER3 DXD. So at this point, we still really only have two decent lines of therapy before we hit docetaxel for the most part. So it's really interesting to see what will happen in the future, but a lot of personalized decisions. And the biggest thing is for those the RadOncs online, I think the biggest difference compared to the studies is how we use radiation to get the most out of our drug therapies and do the best for our patients. So if there are no questions, I'll move on to exon 20 and then uncommon mutations, and I'll move pretty quickly because I don't want to take too long. So EGFR exon 20, I don't show it here, but really this is without making light of it too much, like I can't remember how many times I would read one of our molecular reports, and there's about 3 seconds in your head when you have this, maybe a high pretest probability patient. They're young, they're fit, maybe they have less or no tobacco use, and you're like, yes, EGFR. And then you read a little bit further and you see exon 20 and you kind of just get deflated. So it's a difficult to treat mutation. Again, all that same high propensity to the brain. And unfortunately, the TKIs just really haven't worked there. And I don't give an exhaustive review, but I'm going to jump right to what's our best therapy, what's our best Health Canada approved therapy. And that's going back to this amivantamab drug. So it used to be chemo was our standard of care here, unless we had a clinical trial. And now it's amivantamab plus chemo. We can give amivantamab after chemo, but it's not publicly funded. And so in this was a study where they added ami to chemo, and basically what you see is that a very strong hazard ratio, just under 0.4, adding ami to chemotherapy. It comes with all those toxicities I talked about before, but you get a stronger response, more shrinkage, fewer patients who progress through it or have progressive disease as a best response. But again, all of these same toxicities as we talked about with Mariposa 2. It's essentially the exact same treatment, but again, you are getting toxicity, just this is now in the front line setting, whereas Mariposa 2 is in the second line setting, but all these same things, paronychia, hypoalbuminemia, and so on. And so our options in EGFR exon 20 is platinum pemetrexed with or without amivantamab, and then not a lot of great treatment after that that's available, but clinical trial, clinical trial, clinical trial. I suspect you, with your population, you have access to more of these than I do, but I do know, we have a sunvosertinib trial first line here, and we've had poziotinib, which was a terrible drug in many aspects in the second line plus setting, but we haven't had many of these second line studies. We've gotten mobocertinib and stuff for patients in the past, but that's no longer possible. But there are a lot of really good TKIs, sunvosertinib, furmonertinib, which used to be called fur with a U, monertinib, and zipalertinib, which all have some level of approval in China. They're all being examined in the first and or second line setting in trials across the world. So there are good TKIs here, which I'm not going to go over exhaustively. But as you can see, some of these drugs, sunvosertinib, 50% response rate in the pre-treated population. In the treatment naive population, the response rate here, 78%. So there are good drugs out there that are coming that are going to be oral, and it'll be great to have them. But right now, it's AMI chemo, which is less convenient for patients. I'm excited to have multiple options. Hopefully, we'll be able to use both. So really quickly, I have to flip presentations. For formatting, I was having troubles when I tried to merge it all into one. And again, I'll move quickly because I want lots of time to chat and answer questions or just chat freely. So I guess so now just to kind of look at the EGFR mutations really quickly. So I know I talked about this at the very start of it, but if we really want to start looking at some of these, so if you look at the pie on the left, where you see the exon 19 deletions and the L858Rs, and this was a population that included T790M, so pre-treated patients that developed those, what you'll see is that in addition to exon 20, that kind of light pink color, there are other mutations. And here they describe them as being only around 12%, but really it's probably higher. And it's based on these different pockets. So the common EGFR mutations have a pocket that, erlotinib, gefitinib, osimertinib all fit into. When there's a T790M mutation, say osimertinib fits in, but the first generation drugs don't. Exon 20, though, again, the conformational change in that pocket is different. So a different group of drugs fit there. Now, osimertinib actually can be effective against one or two of the exon 20 insertions. I'm not advocating that you would use it there, but in some of the, actually even one of the common ones, it can have some efficacy. But in general, it doesn't fit in there so well, but some of the other drugs do. And, even afatinib has some activity there. But some of these newer ones, these mobocertinib, sunvosertinib, furmonertinib, have some activity there. But the big thing is uh, how much activity can they have without having too much EGFR toxicity is the balancing act. Because if you start to get into a lot of HER2 and EGFR toxicity, the drugs are much poorer tolerated. And then there's this group of mutations called PAC mutations, which are basically uncommon mutations in that exon 18 to 20 range where they have a unique binding pocket. So that PAC mutations does not include L861Q, which is a fairly common, uncommon EGFR mutation. But you don't have to worry about that exact detail for now. So really, out of these PAC mutations, so again, we're looking at these exon 18 to 21 mutations, not including exon 19 deletions. It does include exon 19 duplications or insertions, though, without deletions, but those are actually harder to treat even within this PAC mutation group. And so when we look at what's worked here before, well, really, if we look at the Lux lung studies, if you don't include some of the exon 20 insertions, Afatinib does have activity, but it comes with the toxicity of afatinib, which doesn't get into the brain as well as some drugs. So there are other drugs. So David Blanchard presented this at WCLC last year. Furmonertinib, it used to be called FU furmonertinib, now FI furmonertinib. But anyway, so this was a randomized two different dose trial of these drugs. And really what they show is particularly at the higher dose that a very good response rate, although only a bit lower when you look for a confirmed response rate. This data was fairly immature. The median follow-up, I don't think I have it on the slide, but it was only something like 5 months. So many of the responses weren't confirmed. A good looking waterfall plot, and these were in this is the treatment naive cohort I'm showing. So good tumor shrinkage, particularly at the higher dose. Some off-target EGFR toxicities, but not as much as what we see with, drugs like poziotinib, which isn't being developed anymore, or even afatinib, but still more than what we would see with maybe a drug like osimertinib in a trial-to-trial comparison. There's evidence for AMI laser here too from one of the arms within Chrysalis, and I won't spend much time on it. But again, the same PAC and non-PAC mutations, including L861, which is non-PAC. But in half of these patients were treatment naive. So if I zoom in on the treatment naive population, a very good median PFS of 19 and a half months. So that's higher than what we've seen reported for other uncommon mutations, which are a fairly heterogeneous group. But again, 19 and a half months is a very good response for AMI laser in this population. And again, I'll refute some of this data in terms of their real world evidence cohorts. But again, what you're seeing in a treatment naive population is a fairly good curve where a lot of patients are getting, a year to 2 years plus of benefit out of AMI laser. So really quickly, I'll mention the Ocelot study, as you have been a wonderful contributor to that. I don't have today's up-to-date numbers, but I think you might be second, but I think in this slide you were tied for first. But anyways, regardless, not trying to make it a competition. London is fourth, so you're better than us. Anyways, so in Ocelot, there's a cohort for patients with uncommon EGFR mutations. That's very broad. It's basically anyone who wasn't on the um, Flora study, excluding exon 20 insertions. And so, yeah, here are the numbers. Yeah, I guess you were tied at the time that I made the original slide at 32, and I think it's gone up a little bit. We've adjusted this to 235 patients total, so we're actually right on target with enrollment, and we're expanding this to 105 in the first line. But so it's been an awesome all Canadian effort. But so really, what I wanted to add from Ocelot, where we're testing osimertinib single agent in this uncommon EGFR mutation population, we've had a median PFS of 16.5 months. And it does a pinch better if you get rid of some of the really uncommon complex like exon 18 and 19 insertions and so on that wouldn't have counted as a common mutation. Overall survival, the data is still quite immature, but more than 60% of patients are still alive at 2 years. We'll have to wait and see kind of over more time how it shapes up compared to those with common mutations and a good disease response. And this is a really pragmatic trial where a decent number of patients have outdated imaging at baseline. Scans are mandated every or only mandated every 3 months. So to confirm a response is harder because they really have to be responding through 6 months. And so when we look really quickly at how are these different drugs working here? So osimertinib with Ocelot, 16 and a half months, Chrysalis, 19 and a half months, furmonertinib, they didn't present it, but their response rate was higher than Ocelot's and about the same as Chrysalis too. And so we have a late breaking abstract accepted for WCLC, but we don't know what kind of presentation or anything yet. And this data is all going to be updated based on a database lock on May 30th or so. So we're looking forward to presenting more of it. But so to summarize, EGFR uncommon mutations are not really that uncommon when you look at exon 20 and these other ones. PAC mutations, which are this new term to kind of cover kind of a group that do better than the really weird EGFR mutations, but exclude that L861Q group. But in general, afatinib is technically the Health Canada standard of care there, but because of Ocelot and other clinical trials, there are better options for these patients. But technically, board exam wise, you should answer afatinib, I guess, for the trainees. Perfect. So I'm happy to answer any questions people have. I hope I didn't run too long there. So thank you.
Thank you so much. That was perfect. I know we've had a few questions in the chat that have been answered. Does anyone else have any questions that they wanted to voice now?
Hi, Dan. It's Alex. I have a question. Thanks so much for the presentation overview of EGFR. We certainly, as you know, see a lot of EGFR patients in our center here at Sunnybrook. The first question relates to what your institutional practice is in London as it relates to when you guys are giving, let's say, lung rads while the patient's on Tagrisso. So here, we tend to hold the Tagrisso during the thoracic radiation. There's some studies that suggest an increased risk of pneumonitis, and then there's other studies that have come out that suggest it's not an increased risk of pneumonitis. So in your view, are we kind of just treating ourselves by trying to not give it the same time and fear of toxicity, or do you guys just kind of go full steam ahead with a TKI concurrent?
Yeah, I don't necessarily know what everyone says. I think in general, if it's thoracic, if there's a decent thoracic dose, then we're holding osimertinib, although with a fairly brief washout, like 1 day before, 1 day after. I've had a patient die. Now, mind you, that was kind of oligometastatic, almost like stage 3 disease. They had a large radiation field. And then I gave them kind of Aussie afterwards because they had a solitary bone met. And they actually died of pneumonitis that clearly was well outside of the radiation field. So I'm more shy with it maybe than some would be, but so I think our standard is hold it during lung rads, but very quick washout. If it's extra thoracic disease, we typically don't hold it. Although I think some rad-oncs might still tell the patient, but I don't think there's much harm if they're just holding it for a few days anyways.
Yeah, so it's pretty similar to us. And the second question kind of relates to that. So there's this North Star randomized study out of MD Anderson and Sloan Kettering and a couple other US institutions. We were approaching Canada, but this was before Tagrisso was approved. And it basically is looking kind of like Syndas, where you give RADs very quickly up front as like local consolidation. So you might be on Tagrisso for like a couple months, and then you treat up to 5 sites of disease randomized with RADs. And so the readout for that is coming out soon, potentially even this World Lung. If let's say it's positive, I forget if the primary endpoint is PFS or OS. So let's say it's positive, right? And you've just shown data about first line Tagrisso versus other options, TKI plus chemo and et cetera. How would you sort of see that fit in our Canadian landscape? Because Tagrisso is covered, RADS is covered. And presumably, if there isn't an increased risk of pneumonitis, like, would you view that as an attractive option? Or, of course, could also be difficult to mobilize for, let's say, centers that don't have a rad-onc center nearby.
Yeah, I mean, and especially if you were looking for an option, like if you were trying to find a way of giving someone more than Aussie mono, you know, but you didn't want to add one of those more toxic things like chemo. So I think that would be interesting. I guess it would depend on how much lung dose there was. If people were getting like, so sorry, does North Star use like palliative? Like, is it like 30 and 10
So
or is it like
basically,
SBRT?
it's up to patients can have up to 20 sites of metastases, but you treat up to 5 up front, and it's
Okay.
dealer's choice of what the treating team felt was safe. So it could be like a wide palliative field, but it's probably going to be predominantly SBRT, is my guess.
Yeah. I mean, I have had some people who've had SBRT for oligoprogressive disease, and then they anecdotally get a bit more local architectural changes in the kind of high radiation zone, even though a lot of them have been asymptomatic from it, because fortunately, a lot of these EGFR patients have pretty good lungs. So, I mean, I think I mean, I would certainly be really open to that. I don't think I would shy away too much just because of the osimertinib, but I would probably want to have discussions at our site about what do, because there's mounting evidence of it also in that kind of oligo residual, although I don't think there's any randomized. I'm trying to think, I think if there's a randomized trial, I think it's more 40, 50 patients and mostly in Asia, but still, I think we'd want to talk about how would we imagine using this in an effective way. Sorry, I didn't include that, the oligo residual study. I can't remember because I'm getting confused of how many of them were non-small cell and how many of them were EGFR specific too. But what do you think your center will use it to you and the med oncs?
Um, Possibly. I mean, we treat a lot of patients with EGFR with RADs. We also, I guess, outnumber the med-oncs. So I think that we'll have to see the data first. But we do treat a lot of oligoprogression. That's for sure.
Yeah.
And bring that up front. Yeah.
When I first started, med oncs had like like our average wait list for lung was like more than 2 weeks by far, and rad oncs had no wait list. So things used to be different when the rad oncs were seeing people and they didn't even have a med onc appointment for 2.5, 3 weeks. Some of the decisions would be slightly different than maybe they are now too. Now I see them before the rad oncs, and I can usually get osimertinib approval faster than they can get simmed. But anyways, so no, interesting.
Great discussion. Actually, I'm glad you brought it up, Alex, because one of the main questions that I had was if we start using amivantamab for all these people, um, are the rates of pneumonitis going to be higher? And like if we're wanting to use radiation for oligoprogression to keep people on, how's that going to impact those rates of pneumonitis? I'm not sure. I was trying to look up, there's like a small real world study that was published last year where they said that it was only 60 patients or so, and they said that radiation seems to be safe with AMI. So I don't know, Dan, if you have experience with that yet, because it's so new, but have you seen radiation combined with AMI?
I don't think I've seen anything that said it was more dangerous, and I
Yeah.
think there was something even showing less ILD changes with lazertinib than Aussie, but I could be wrong there.
Oh,
I
with
don't have the
lazertinib? Yeah. Yeah, so I think it's interesting because um it may allow us to use, radiation, to continue to use radiation and not have those severe toxicities as we saw with OC. But
can I
hard to
ask, do you
know.
guys any med onc or rad onc, I guess if you want to answer too, do you have a sense of maybe a year from now, assuming everything's funded without any really, do you have a sense of how much Aussie versus Flora 2 versus Mariposa will be used? Maybe not for you individually, but as a center. Does anyone wage a guess? I don't want to put people on the spot.
It's tricky. I mean, I'm just being conscious of the time we're at 1:30, but I would
Hmm.
say it seems like the amulozertinib is the most toxic, like with the venous thromboembolic disease and that. So I feel personally I would shy away from that one if the benefits are quite similar, right?
Hmm.
And again, I think it all comes down to patient selection, right? Because if we have a lot of older, frail patients, they're not going to tolerate AMI as well either. And I've found I am also starting to use like the prophylactic tetracycline type family of drugs to try to prevent the toxicities, but we're still running into a lot of toxicities.
Yeah,
So hard
again,
to predict.
I would say people here, like not me, other people have basically said the same thing, and I agree that I think our group is mostly thinking it's going to be like because we use a lot of SBRT
Hmm.
as well, which the trials don't really incorporate
Yeah.
properly, but for to do the best for patients. But um, I think that the funding details around Mariposa 2 and Flora 2 will probably affect things a lot, but I think we're going to see more Aussie monotherapy and Flora 2 and Mariposa 2 and second line, if I had to guess.
Yeah. Yeah, I think all the pieces of puzzle will come together once we know how we can actually
Yeah.
use everything, right? If we throw the kitchen sink in the first line, then we have very little to use later, but I think we have to see how all the funding shakes out so that we have multiple lines of therapy to use.
Okay.
Thank you so much. We're going to have to cut it there, but if
Of
anyone
course.
has any other questions, I'm happy to share those via email. And thank you so much to Rachel and the team from AZ for sponsoring this talk. And again, thank you, Dan, so much for this great talk.
Yes, thank you for having me. Take care, everyone.
Thanks.